You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone. Welcome back to the Just Medicine podcast. Once again, my name is Audrey Esemezi, and I'm an incoming second-year medical student at the University of British Columbia. As mentioned in my previous episode, my focus for my podcast episodes is on health equity with respect to vulnerable populations. This week's episode is about an immensely relevant and pervasive topic, HIV, but specifically HIV interventions in the Black heterosexual male community. Human immunodeficiency virus, commonly known as HIV, is a topic that is definitely represented in the medical curriculum. Still, I wanted to gain and share insight into populations of people who are not only disproportionately affected by HIV, but are also underserved in terms of interventions and treatments and are deeply affected by social factors such as racism and discrimination. The population being Black patients, and specifically for today's episode, Black heterosexual male patients. While preparing for this discussion, I found that according to the Public Health Agency of Canada, 25% of new HIV cases in Ontario are patients of African, Caribbean, and Black descent. Of course, this issue is not specific to Ontario, as the Canadian Surveillance Report published that as of 4 years ago, about 20% of new HIV cases in Canada were Black men, even though Black people in Canada are only about 4% of the population. These statistics provide evidence of the disproportionate effect of HIV on the Black male and Black community in general. Pursuing a career in medicine makes information like this not just facts or statistics. It means something that there are populations of patients that experience these realities and often feel disregarded by the medical community. I think it should also mean something to everyone who is in this field, and it is exactly why I reached out to today's remarkable guest, Dr. Michael Bassi Etowa, who conducts research aimed at HIV vulnerability and resilience in Black communities. His other research interests include social determinants of health, including health equity, as well as human capital welfare and development in agrarian communities. He is currently a post-doctoral research fellow at Daphne Cockwell School of Nursing at Toronto Metropolitan University. He is also an associate scientist at the HIV Treatment Network in Ontario. He also has an extensive educational background in Nigeria. His cultural background is of African descent, and this is another important aspect of my podcast series, having speakers of diverse cultural backgrounds to further emphasize the gift that is the representation of diverse voices. And I'm so delighted to be having this discussion. Dr. Etowa truly has so much great insight and knowledge to share with us today. So welcome, Dr. Etowa. How are you doing today?
Thank you. I'm so delighted to be part of this podcast. Thank you.
Thank you so much. So we can jump right in by you just telling us briefly about yourself, your education, and your career path.
Okay. Yeah. Well, as you have described earlier on, I am Dr. Igbe Etowa, also called Michael. Yes. I came to Canada from Nigeria as a researcher in 2018. Since then, I have had 3 postdoctoral fellowships to conduct research on different topics in social determinants of health. Currently, I am a postdoctoral research fellow at Daphne Cockwell School of Nursing, Toronto Metropolitan University, and also an associate scientist at the Ontario HIV Treatment Network. While in these roles, I have received the Winston Husband Leadership Award in strengthening the response to HIV among Black communities in Ontario. I've also had opportunity to receive a research grant, CIHR research grant on HIV response intergenerational participation among Black communities in Ontario. So prior to arriving in Canada, I've worked as a PhD prepared assistant professor in the field of agricultural economics at the University of Port Harcourt in Nigeria. So while in this role, I had interest in conducting research that links agriculture and human health from the perspective of welfare. And my interest in HIV and vulnerability and resilience research among the Black communities in Canada started from my experiences doing research that cuts across agriculture and health. And also during my first visit to Canada in 2013, when I had opportunity to connect with interdisciplinary researchers, most of whom were in the public health domain. That landed me the opportunity to come back to Canada in 2018 to conduct research as a postdoctoral fellow in the areas of addressing HIV vulnerability and promoting resilience among Black communities in Canada. Thank you.
Wow. Yeah, that is quite an extensive educational and career background. It's quite amazing the things you've accomplished and your interests. It's so powerful to hear someone following their path and always being inspired to enter new research interests and expand themselves and their impact. So it's quite amazing to be hearing from you today. And you kind of touched on this, what inspired you to study the social determinants of health, including HIV vulnerability and resilience in the Black communities. But do you have any more specific details as to what really made this a big research interest for you in the last
Okay.
couple of years?
Yeah. Well, I've been passionate about looking at the vulnerable population right from when doing agricultural economic research by looking
Mm-hmm.
at some of the factors that impact, for instance, their productivity in the agricultural sector. And that led me to looking at human capital as an approach to addressing some of the issues of productivity. You can't talk about human capital without looking at health. Also,
Right.
my social connection that led me to doing research in the health sector, looking at social determinants of health since I came to Canada, enforced my interest in that regard. I've had opportunity to work with diverse teams in the areas of nursing, some of which who are also in the area of uh, clinical practice and also doing research. So I had opportunity to rub mind and learn about many of the issues that impact health of the Black Canadians. And that has spurred my interest to intensify my effort in research in that area, specifically targeting issues of HIV vulnerability.
I was wondering, based on just learning from school and my education, there is that knowledge that Black populations in general are disproportionately affected by HIV, like many other diseases. But I was wondering why the Black male population is your research interest. Is there information specific to Black male patients that make them specifically more affected by HIV?
Okay. Yeah, well, when I came to Canada newly, yeah, my first research focused on actually on Black women. The first 2 years, Black mothers living with HIV. In that
Mm,
particular research, we looked at some of the policy guidelines. How does policy guidelines influence the infant feeding practices of Black mothers living with HIV? And how does even the socio-cultural factors or the cultural factors in which these women lived in, both in their country
mhm,
of origin and also the ones they experience after migrating to Canada, how does it impact their choices of infant feeding? And also
mm,
considering the fact that they live with HIV, and how does the policy intersect with socio-cultural factors to influence their decision? And how does this intersection also impact their psychology or their psychosocial attributes? So we looked
mm.
at all that, but then moving from that research, I now started doing HIV vulnerability among heterosexual Black men in my second postdoc. So that was the point at
Mhm.
which I moved to studying HIV vulnerability among heterosexual Black men. But the question you asked about why is this research of importance? It is highly important
Yeah.
because before now,
Mm.
most studies addressing the issues of HIV have either focused on women, especially, and also looking at Black women, and have also focused on the LGBTQ community. And there have been a number of work addressing issues of HIV vulnerability in those two communities. But there are very sparse studies looking at heterosexual Black men. And even a lot of intervention do not focus on addressing the issues of heterosexual Black men. And yet, heterosexual exposure is the second means of HIV infection. So that makes the research also very important. And they also have some of the social factors that impact their health-seeking behavior, like the issue of masculinity, the experiences of racism among these Black men, all interact to impact their health-seeking behavior, which also heighten their HIV vulnerability. I think a few of these makes research addressing the issues of heterosexual Black men in terms of HIV vulnerability important.
That really opened my eyes to something, because exactly like you said, we've studied HIV in different populations in our curriculum, both in medical school and other undergraduate degrees. But there are other populations that are not talked about as much, and not. It's really amazing to have people who are looking into these niche areas and looking at these populations that are underserved, and making sure there is awareness and there's better research in those areas. So it's really great to be hearing this, and for myself and anyone who's listening to know there are other populations than what is being presented to us that are suffering and being affected by HIV. I'm sure in other diseases this can apply to so many areas as well. So you have a 2023 article about HIV misconceptions about heterosexual Black men and communities in Ontario. And there was a lot of linkages between misconceptions in HIV and poor HIV outcomes. So I was wondering if you could speak to what these misconceptions are, specific to HIV.
Okay. So in that particular article you talked about, cited Antabi 2021, who defined HIV misconception as ideas and beliefs about HIV transmission that are proven to be factually inaccurate. But based on our own analysis from that particular article, studied HIV misconception based on the 18 items HIV knowledge questionnaire designed by Carey and Schroeder in 2002. We determined that a participant has an HIV misconception about a particular item on the questionnaire if their response to that question is incorrect. So, for example, item 1 of the questionnaire says coughing and sneezing can spread HIV. So, if the participant response to that question is yes, then we assume that the participant has HIV misconception on that particular item. So the accumulative responses in all the 18 items gives us an idea about their level of misconceptions about HIV. HIV misconception may be based on prior knowledge or beliefs. So, and that makes it a very important thing to study in order to address HIV spread, because once it is an established belief, it is difficult to address, because people will naturally return to what they believe, even if they have new knowledge. So the onus is on interventionists to address this misconception, because it has serious implications for HIV. Okay. Did I address your questions particularly?
Perfectly. This is a theme that I've noticed in different populations, that importance of listening to the patient and figuring out what a patient knows. The best way to help people is to know what they need, what they know, and what they want. Misconceptions can be contributing to poor outcomes, or them not seeking help, or them not following the
Okay.
right avenues to protect themselves from diseases like HIV. So it's really important that as medical trainees, we're aware that patients might have misconceptions and knowing how to educate patients and how to talk to
Okay.
patients and help them dispel any misconceptions they have. So I really like that you shared this is like a big contributor to having poor outcomes. So I feel like tackling this can be really a way to better protect patients and allow patients to protect themselves. So thank you for
Okay.
sharing that. And so, kind of following up with that, I was wondering what factors contribute to these misconceptions.
Okay. So probably before I go into that, let me quickly tell you why misconception is very important to address. They impact
Of course.
the health-seeking behaviors adversely. For example, someone who has misconceptions about mode of spread may have developed negative attitudes towards HIV testing. They can be in denial that condom is effective means of HIV protection. That, of course, will lead to more spread of HIV. They can also be resistant to HIV testing, and misconception reinforces social stigma against people at risk and people already living with HIV. And that will deter those people from uh, testing or even, from seeking treatment or staying in treatment. If they know that the community, because of their misconception, are already holding stigma against them, yeah, they will be resistant to staying in treatment if they're already in treatment, especially if this stigma is also coming from the providers. So now, addressing your question, the levels of misconceptions that we found in our study, we have various means by which we measured levels of misconceptions. As I mentioned earlier, the number of incorrect responses based on the 18 items of the HIV knowledge questionnaire tells us about the level. Then looking at it item by item, we highlighted the percentage of respondents with misconception in five items that have the greatest number of participants with misconceptions. Like I would talk about like 40.1% of the participants wrongly believe that people are likely to get HIV by deep kissing, putting their tongue in their mouth, putting their tongue in the mouth in their partner's mouth, or if their partner has HIV. So yeah, this is actually a wrong belief. Yeah, because HIV is rarely spread through kissing. Then 31.6 percent wrongly believe that taking a test for HIV 1 week after having sex will tell a person if she or he has HIV. That was another one, second highest. Then 25% wrongly believe that a person cannot get HIV from oral sex. Yeah, we know that semen released into the mouth can transmit HIV, especially if there are oral sore. So that was that was a misconception as well. Or even semen, yeah, 23.8% wrongly believe that all pregnant women infected with HIV will have babies born with AIDS. So that's also a misconception, because if a pregnant woman is on antiretroviral therapy and the viral load is suppressed, it's likely that they will have children born without HIV. Then 23.4% wrongly believe that there is no female condom that can help decrease a woman's chance of getting HIV. So those were the level of misconception. Now, talking about the factors influencing HIV misconception, from our study, we identified 3 factors that are associated with increased level of misconception. And the first among them is racial discrimination, mostly experienced in the healthcare settings. was associated with increased misconception about HIV. Then negative condom attitudes, those who already have negative condom attitudes were also likely going to have had a high level of misconceptions about HIV. Then one result that was surprising is that people with delayed sexual debuts also have high level of misconceptions. So factors that are associated with reduced misconceptions were immigrant status, country of birth. Yeah, so should people born in Canada were likely having lower misconceptions, then higher levels of education associated with reduced misconception, then people with high resilience score also have reduced misconception.
I just kind of wanted to tackle some parts of that. So on the end of that, resilience score, can you speak more to what that means?
So resilience often talked about someone's ability to adapt to or to withstand or to overcome difficult situations. So in this case, adapting to and resisting things that can lead to HIV vulnerability. Like, for instance, being able to identify, to have the right information, so have the knowledge to address vulnerability, having the knowledge to address risky behaviors, and also being able to resist it when they come. That talks about resilience. And if you're already in the difficult situation, being able to recover from it also speaks to resilience. So if someone is already living with HIV, is the person able to live with it, live healthy with it? So by taking steps to do all the right things he needs to do, like staying in care, taking treatment, and all that, will speaks to the level of resilience of that person. Yeah, but in this case, we measure resilience not just based on HIV, but how people respond to adapt or respond to difficult life situations using the resilience scale. That was how we measure resilience.
I see. Thank you so much for clarifying that. That now having that explained, that definitely makes sense as to how that will affect both the misconceptions, but also the outcomes. And it's really interesting also because some people don't have the luxury of having resilience. So there are just so many levels at which patients are vulnerable. Some patients are more vulnerable than the other, depending on whether they have the access to resources that make them more resilient. So it's really interesting to hear that. So I was wondering how healthcare providers, especially non-racialized ones, who are serving Black patients, influence the Black population's HIV misconceptions as well as their poor health outcomes.
So in healthcare setting where the provider is not receptive to culturally safe and open dialogue, racial discrimination may set in. So once that racial discrimination set in, the Black patients who is in contact with that provider will not have trust in the information being provided, in this case, HIV information, and that leads to formation of HIV misconception. So HIV misconception may be proliferated by healthcare providers. They also stand the chance of reducing HIV misconceptions. So studies, if you look at, there are studies who have found association between racial discrimination experienced from the health sector and HIV misconception. So if there is racial discrimination being experienced by the Black or marginalized population in the healthcare settings, then they are likely going to build distrust for the information or mistrust for the information they have from the healthcare provider. And that will lead to formation of misconceptions, including HIV misconceptions. So several studies have found that association between discrimination experienced in healthcare settings and the formation of misconceptions, like Cole et al. In 2012, Piper et al. 2014 found something like that. And one important thing is that once misconception is found and it is enacted, it also leads to experiencing more discrimination. So a cycle is formed. Yeah.
Right.
First of all, discrimination makes you to form misconception. And once you now begin to enact the misconceptions, you also experience more discrimination. And not only that, within that cycle, as you form misconception, it makes you to be resistant to treatment, not to seek help in the healthcare settings. And it worsens the HIV disease condition if the person is living with HIV. If the person is not already living with HIV, it makes the person more vulnerable. Yeah, because you don't have access to the right information that makes you resilient. And when you become infected, then it now leads to more spread of the virus. So, and the cycle continues. So those are some of the things that happen with misconception in the healthcare settings.
It's really interesting that physician-patient relationship always comes into play, and it's really saddening, honestly, to hear that physicians and healthcare practitioners can be active in that cycle of discrimination and then poor HIV outcomes. So it's important to know that we all have a role to play in as future physicians and future healthcare professionals about how to mitigate these issues and how to make sure we are not contributing to
Exactly.
poor outcomes in patients. And that cultural sensitivity and awareness and humility always comes into play in every aspect of healthcare, and it's definitely very relevant in this area. So thank you for making us really aware of that and how patients are being affected by both conscious and subconscious actions and behaviors of different healthcare providers. I also wanted to talk about the gaps in HIV response and care. So we've touched on the misconceptions and areas that can lead to increased rates of HIV infection. But I was wondering, besides those misconceptions, what are the gaps in the care that patients receive, and also like what are factors that limit access to HIV care amongst
Okay.
Black communities in Canada?
So talking about gaps in HIV response and care, I would say there is sparsity of national race-based data that can clearly show the gaps in HIV response and care in the Black communities in Canada. So, however, the
Okay.
Ontario HIV Epidemiology and Surveillance Initiative, called OHACI, provides useful information on gaps in HIV cascade among Black people living in Ontario. So, yeah, even though the information is not comprehensive, it gives us some idea. Like data collected in 2015 and 2016 showed that Black people living with HIV are diagnosed with HIV were slightly less likely to be in care. They were also less likely to be on antiretroviral therapy and be virally suppressed than people living with HIV in the general population. Then in 2017, Black people who were newly diagnosed on the average took slightly longer to receive their first viral load test and achieve viral suppression. So that may be seen as some gaps. Then
Yeah.
in 2018, there was no statistics about the undiagnosed fraction of Black people living with HIV. So that might be a gap in terms of getting the race-based data to clarify that. But if we look at overall, many Black people diagnosed with HIV are almost attaining, they are close to attaining the goal. That means once diagnosed. So the main issue for the Black Ontarian now to be diagnosed, the first time diagnosis, that means they are not accessing testing. And there are several challenges associated with not accessing testing. Like one of the ones we have discussed earlier on is the misconceptions. If they are built misconception and they experience racism in the healthcare settings, and they also experience stigma, all those makes them not to access testing. And even some of the testing facilities are not accessible to them. And studies have shown that inequalities or inequities, is the main barrier to HIV testing or HIV response in the Black community. So, lack of access to culturally safe programs that provide Black people opportunities to dialogue about their vulnerabilities and co-create solutions was found in a study as one of the key barriers to HIV response and even access to testing. So discrimination is another one which we have mentioned earlier on. Poor representation of Black populations in healthcare decision making also contributes to that. The lack of accessible information in relevant languages. So some migrant population do not understand some of the language, like French-speaking population trying to seek health in the English-speaking provider or healthcare system becomes difficult for them to interact, even in culturally safe and understandable language. So cultural safety is another thing that hinders people. Cost. Then we talk about stigma, HIV stigma, which is reinforced by discrimination. So stigma hinders Black people from testing and even from disclosing their HIV status if they've been diagnosed, it increases their vulnerabilities. It makes them to be socially isolated, and it increases depression and overall leads to delays in testing, diagnosis, linkage to treatment or care, and poor health outcomes among the Black communities. So those are the factors that hinder response to HIV testing in the Black community.
I feel like there's just so much to learn from all of this. And it also, one, just shows the importance of having research in these areas and having better representation of different populations in the scientific research field. As you said, a lot of patients in the Black community for different illnesses are not highly represented when it comes to research, and that affects what we know about it and if we don't know a lot about it, how can we tackle it the right way? So thank you for being one of the people who are ensuring that more research is done in these areas. I wanted to ask about, because I do think it's as important as it is to talk about all of the issues and misconceptions, I also want to know that there are ways to combat these issues. So how, as a medical trainee and as a future physician, would I help a patient from the Black community or a racialized community dispel any misconceptions that they have for diseases such as HIV? And then to kind of second that question, I wanted to know what culturally safe care for this topic looks like. So I know it's a kind of a heavy question, so we can kind of start with how to dispel those misconceptions.
You asked the question and somehow you answered it. So, misconception can be addressed by putting in place culturally safe education or program or healthcare in the Black community. So it will many heterosexual Black men, which are our main focus to address the issue of misconception, like engaging them in dialogue, bringing heterosexual Black men of different generations together to have dialogue in an intergenerational communication program, which is one of the projects I'm doing, will help them to talk about some of these things. And because it is about Black men themselves, this issue of distrust or mistrust would not be there. And yeah, while the discussion goes on, it will be based on their own cultural settings, and it will take into consideration some of their cultural beliefs in terms of discussing issues around sexual health, around HIV prevention, and all that. And that would make the information to sink in, to dispel every misconception they've had. Also providing in the healthcare setting, educating healthcare providers in the areas of cultural safety, and will also enhance how they interact with heterosexual Black men, and also addressing the issue of discrimination will help them to understand how to tackle approach Black men and provide them with the right information. Also, when people go for testing, HIV, they should be educated in a culturally safe manner about some of this information around HIV knowledge, so that will help them to dispel misconception. And it has to be a kind of intense effort, a constant effort, because once misconception established, it is difficult to address. So, and you have to give it that effort required, continuous education to dispel this misconception, culturally safe education. So that's my thinking.
I feel like you read my mind, because I also wanted to ask a question about your project protocol on HIV response, intergenerational participation, so your HIP intervention. I also really love the name of that. So just wondering, what is the overall goal of this project, and what led you into developing this
What
project?
led me into developing this project? Yeah. So in 2020, we engaged in the project in which I was a post-doctoral researcher as well, called We Speak. So We Speak project addresses HIV vulnerability and promote resilience among heterosexual Black men. So in that particular project, we engage in one of the phases of the project, we engage 60 heterosexual Black men in Ontario through grouped concept mapping. So the group concept mapping enabled the heterosexual Black men, alongside with stakeholders, to engage in dialogue to determine or to brainstorm and generate the best practice to address HIV vulnerability among heterosexual Black men and the community in general. So within that, they generated some statements. They also ranked those statements in order of importance and feasibility. And through the analysis of the concept mapping processes, we arrived at intergenerational communication for HIV prevention as the top highest in terms of importance and feasibility to implement in order to address HIV vulnerability. So it's based on idea from this project that led me to trying to develop or co-design the HIV response intergenerational participation project to address HIV in the Black community. So this is a project that will be co-designed, the Black community, the Black heterosexual Black men themselves, and implemented, pilot tested among selected heterosexual Black men to first the effectiveness of this approach, even though the approach a community-informed approach, best practice approach to address HIV vulnerability.
It's really interesting to hear about things you learned in curriculum and theory. So we learned about when providing care to different vulnerable populations or conducting research. One of the best practices is involving that population in developing those protocols and those plans. So it's really neat to hear that happening in real time. A lot of things that I've learned in my medical curriculum has just been in theory so far, so I haven't gotten that hands-on experience, but I always love hearing how it applies in real life. So thank you for sharing, and also for the work you're doing, like integrating the Black community into their own healthcare, empowering people, and kind of initiating those discussions. Another thing that also I've found in a lot of different populations is that idea of intergenerational care and intergenerational focus. A lot of ideas and customs and practices and trauma is passed on through generations in a lot of marginalized and racialized communities. So targeting that aspect, I think, is a really amazing way to change generations of people and empower people, and hopefully contribute to lower HIV infection rates among the Black population and better outcomes in the Black population over many generations. So it's really neat to hear about that. Based on that, I was wondering if your HIP intervention model can be applied to other vulnerable or marginalized populations.
Looking at evidence from other models that looks like the proposed HIP intervention, like in the United States, there've been parent, family, and community engaged HIV prevention program, specifically called the Collaborative HIV Prevention and Adolescent Mental Health Project, which was done in the US. The project has been found to be effective in addressing HIV vulnerability among adolescents in the United States because it bolsters the family dynamics processes that is related to youth risk-taking behavior by providing them opportunities for dialogue with their parents, including biological parents, grandparents, relatives, and sometimes even community, just as we planned in the HIP project. So, and even the US project have been adapted elsewhere, and it was found successful to address HIV vulnerability, like in Argentina and in South Africa. It has been used and it was found to be successful.
Wow.
So, and there are several studies that looked at how intergenerational communication, which is the key concept within this intergenerational intervention, can be effective. Like a study by Links in 1994 found that it promotes role modeling. So through the program, older generations become role models for sexual health and HIV prevention behaviors for the younger generations through the communications that takes place. Also studied by Winskell et al. In 2016 found that intergenerational communications allow for cultural appropriate approach to sexual health and HIV prevention education. So just as we said earlier, then it also reduces social isolation. Once someone is isolated, vulnerability happens because social isolation is part of what leads to HIV or what we can describe as HIV vulnerability. But through the processes of intergenerational communication, the issue of social isolation is removed because there is now a connection between generations of people, in this case, generation of heterosexual Black men, through dialogues that constantly takes place. And also, resource sharing is also one thing that is found in true intergenerational interventions, like maybe older people living with HIV through their connection with the younger generation who are still actively working can benefit from resource sharing and will also have the capacity to address their HIV affectedness, uh, and thereby reducing the impact of HIV and also vulnerability overall. Then intergenerational connection can also serve as a safety net. So once you are connected, you are building social capital with the connections, the intergenerational, and that helps you to address a number of issues, including issues in terms of financial resources that you may require to address some of your concern in terms of addressing HIV, assessing care, assessing treatment, and all that. So some studies, like study by Foster in 2007, found that as well. Yeah, the HIV response intergenerational participation can be effective in addressing HIV vulnerability in marginalized communities, as shown by various studies, including even the CHAMP model, which we described earlier, that is originated in the US and has spread across many countries. So it can be a very useful avenue to address HIV.
It's really lovely to hear that a lot of these interventions do translate to other populations and other aspects of care. It's nice to have things that can help not only one population but other populations. My previous episode was about my refugee populations, and I can completely see the parallels and that social isolation. And I really love what you said about when dealing with populations that do suffer from social isolations, connecting them to different generations does bring about that community and can help them combat that isolation that is contributing to worse health outcomes. And there's just so much to learn from hearing about different populations, because nothing is ever mutually exclusive in healthcare. Learning from this discussion can help somebody else who's targeting another population. I always wrap up discussions by connecting to medical students. So I was wondering if you could talk about critical health literacy. Specifically, what is it and how important it is in terms of medical education?
So critical health literacy can be seen as an individual's ability to access, understand, and process basic health information or health service. So critical health literacy supports informed health decisions, and it also enhances stronger patient-provider relationship. It enhances stronger medication adherence. So, but low health literacy can lead to difficulty navigating the healthcare system and misinterpretation and misunderstanding of health directions. So that means when there is low health literacy, it boils down to the misconceptions we were talking earlier. Then, how does it apply to the HIV situation? We look at it in three levels. There is critical HIV literacy, which is the ability to analyze population health information to gain a critical understanding of HIV vulnerabilities in the context of social, economic, environmental determinants, and to engage in organized effort to advocate for health equity. So that's critical HIV literacy at a broader sense. When you are able to do this, then you are able to, when you have critical HIV literacy, it empowers you to be able to advocate for health equity in the community. Then functional HIV literacy is the ability to obtain relevant and accurate information on HIV prevention. So then interactive HIV literacy is the ability to extract those information that you have obtained from different sources to make HIV-related sexual and health decisions, and to be able to interact with the service providers and to meet the HIV health needs. So once that talks about interactive HIV literacy, but you asked a question, how are all these useful to a medical student? So the term is very important to a medical student.
Yeah.
And it is important for a medical student themselves to have all this level of HIV literacy and critical health literacy in general, because it highlights their future roles and responsibilities as healthcare professionals who will be providing accessible, culturally safe, and inclusive health information and resources to their clients and the community in general. So that is how I see it as being important and relevant for a medical student.
Thank you so much, Dr. Etowa. That was quite a beautiful way to summarize this discussion and the importance of awareness and education and just informing people of different health equity issues, which is the basis of this podcast. I truly have learned so much from you today, and I'm sure whoever listens to this will learn so much about a population of people, the Black heterosexual male community, and interventions that are being held to tackle HIV outcomes in this community. So I'm really grateful that you were here to share with us your deep and extensive knowledge. And I'm more grateful really for the work that you're doing. It is so important to me as someone who identifies with the Black community, but also someone who wants to be a physician and wants to help different populations and wants to contribute to a more equitable healthcare system. So thank you again so much.
I hope this becomes useful to the healthcare professionals and also the Black community and marginalized populations in general in terms of improving health equity and addressing some of the social determinants of health.
Thanks for tuning in to Just Medicine.